So here's an outline for today, kind of to organize your thoughts, create a scaffolding. So we're going to talk about the quality assurance program for stereotactic. So that could be body or intracranial. So just high precision. We'll talk about like the prerequisites, what you should have in place before you initiate your program. And it sounds like not everyone has a program in place. So this is a good time to discuss these things. It's easier to build something whole than try to repair something. So we're also going to talk about the methodology and equipment, the process chain, and process is really, that word is key to everything, because an efficient process is a safe process. I'll say that again, but an efficient process is a safe process. So if you create something that works well, that's going to work safely. If it's got, if the gears grind, that's where mistakes can happen. So process control, so controlling, making sure that it goes smoothly. And then obviously end-to-end testing, and that'll be mixed in the slides. I'll give you a heads up that I will discuss it again next week, because it is such an integral part of the process. And then we'll also touch on pretreatment verification. I'm not sure what the IMRT implementation is, because a lot of that kind of carries over. So if you're doing IMRT, you may already be aware of that. So that's why I put for the newcomers. So my slides, I'm going to be up front. They're kind of wordy. That's okay, because they're for you to review later. They're not there for I'm not going to read them all, and I'm not going to expect you to read them all, but I want you to have this information. So quality assurance is a team effort. It's not something that's done by one person. It's done by the whole team. And you can dial in specific parameters with quality control, but it's really the departmental organization. It's the system. That's how you ensure quality, is as you build a good system. And like I mentioned before, process management. So managing and controlling the processes. This is kind of the focus of the presentation. End to end is one of those ways we assess the system. So first and foremost, like I said, it's a team effort, but there should be clear duties and responsibilities. The nurse has her role or his role. The therapist, the technologist has their role, the physicist, the physician. So what those roles are should be very clear. Who's responsible for checking what item? Those things should be known. And you shouldn't really start this process until it's clear who your team is and what their roles and duties are going to be. It's essential, because you don't want someone to say, oh, well, I didn't check that. I didn't know it was my responsibility. You always want everyone to know what their responsibility is. So with stereotactic treatments, why it's so important that we have a good quality management, quality control, is because there's little room for error. With conventional fractionation, it's over 20, 25 fractions. There's time to correct for something that goes wrong. The stereotactic, when you're talking about 5 or 1, there's no way to recover from a mistake. So it requires high precision. Because it's a high dose and there's a high risk of harm. And this book, I want to plug this book, written by Lawrence Marks out of UNC, Engineering Patient Safety and Radiation Oncology. It's a great book. It's an easy read, and it really talks about the organizational elements of a quality control program. I highly recommend it. And this is showing kind of this image over here is just kind of showing some of the how critical it is to get everything right. So if you've got a dose calculation right up against the bone in the brain, and in between right next to the brainstem, it's really critical you get that right. And because a little shift, you're going to give the brainstem too high of a dose. And if the dose calculation isn't correct, you're not going to actually accurately display that. So it takes a lot of work to get this set up, but we also know that these treatments are effective. So each technique is a little different. I think that's important. I'll reiterate that. Brain is not the same as lung. It's not the same as liver. So you want to tailor your program for each one of those things. We're kind of talking more about cranial today. It's kind of more of the focus. I want to be clear that we used to do frames. We used to rigidly fixate individuals. Frameless is just as good, and more people are actually doing it. Just got to know your system and know what you can achieve. So with all these stereotactic treatments, we used to do them with frames and boxes and we'd use film. But I think it's pretty accepted that now IGRT is a requirement for doing this properly to ensure that you're shifting the patient well and you've got them in the right position. And that's why we'll talk about IGRT next week. So again, the one of the parts of, or what makes stereotactic such an important or critical thing to get right is that it's got high dose gradients, and those are often right next to a critical organ at risk. And so that makes the accuracy in positioning and alignment critical. And so this is another example where you're right next to the optic chiasm and the brainstem. So these are common things in an intracranial program that you're going to experience. And we also know that we want to irradiate as little bit of the brain as possible, because there are other issues, like if you're near the motor strip. So getting it right and getting it in the right spot is really critical. So I mentioned this before, frames lock something into position. Masks don't do that. Masks immobilize. They make sure that the person doesn't move, but that doesn't mean that they're going to be positioned in the exact same way. There's always a little play in masks, and knowing that play for your mask system is important. And there's lots of different mask systems. You see here, this chin, it's got an extra fold to make that chin area. The top one's got an extra fold to make that chin area more secure. This other bottom one, it's kind of more of an open face, which is good for surface guided, but it also has like a bridge and a mouth guard. So each of these is going to have their own uncertainty associated with them. So knowing your uncertainty is important, knowing the uncertainty for your system. And this comes into play in end-to-end testing, because end-to-end testing, you're testing the whole system, but you want to know what you can expect to get out of, how good you can expect to get out of each component of the system. So knowing your mask uncertainty is kind of a starting point. And there's been different studies, but the mask uncertainties can be 2 millimeters or more. They can also be less if you've got a really good system, but you just need to know your system and know what's achievable with your system. I also want to reiterate the fact that, or maybe I didn't say this before, but the end-to-end testing is the best you could ever possibly achieve. If it's done properly, it's the best you could achieve, because it's not moving, it's not a patient, it's not breathing. You're setting it up, and it has no comfort level that it needs to achieve. It's static. So that's the best. So knowing that whatever you get with your end-to-end test, that's not necessarily what you're going to get with your patient, because your patient's a living, breathing human. So just assessing each of these points is important. Oops. So going back to kind of process management, that is a form of quality assurance. And I got a lot of these pictures with gears. I think that's a common way to think about systems. You've got all these different gears that fit together to make something move. And each of those gears, to some degree, is either a person or a process. And you can have a well-trained individual, you could have a well-defined process, but it's also important how it fits together in the overall system, because it's those connection points. And with humans, that's often communication. It's those connection points where things can go wrong or can go really well. So having a department that supports a good culture that ensures that there's adequate staffing, adequate training, these are really important. And it's been documented that the things that go wrong, they often go wrong because of the process itself. It's not because the equipment failed, it's because the process failed. So defining and describing your processes is really important to making sure that you're successful.
Peter?
So, yeah.
Will you be talking about how to measure the uncertainty of the masks in this lecture?
In the masks, I'm not going to talk about the masks. That's something that you could do. You could do it retrospectively, like look at your masks, look at the cone beams. I think there's a lot of published studies on that, and that's what this is actually kind of a compilation of studies here. And there, you can look for these studies, and if you want to replicate them yourself, or you can use these ones that are specific to your system. But no, I'm not gonna go into the specifics of measuring uncertainty for a mask.
Okay.
Yeah.
Okay.
This isn't Benedict. Go ahead.
So I guess Mahmoud's question was a simple one. Do you, in your clinic, when you're checking the uncertainty of any mask or any patient positioning, do you use bone anatomy, or do you use the contours provided if we're talking about masks?
Okay, so how do you measure?
Yeah, like how can you tell that the mask is not fitting right, or if it's not certain enough?
Well,
do you use bony anatomy to assess that, or do you use the contours? I guess is his question.
This is, and I mean that's a fair question. So it depends on what you're targeting. If you're targeting the prostate, you're going to use the prostate. If you're targeting something that you can trust, like the spine, you can trust the bony anatomy, use the bony anatomy. I think you always try to get as close to the target as possible using the target.
I agree. I'm sorry. I agree with you, but I guess if he's talking about masks I guess if he's talking about masks for brain, then for the brain, the contours should never change, or typically don't change relative to bony anatomy. So I would say that bony anatomy should be sufficient for brain cases, right?
For brain, yes, I agree. Yeah.
Thank you, Peter. I'm sorry for interrupting.
Oh, no, it's okay, and that's fine. And it should be a discussion, and that's important. It's a lecture, but we don't learn just by being lectured to. We synthesize the knowledge by parsing it and kind of reflecting upon it. So I appreciate the interruption. I'm good with that.
Wonderful. Thank you, Peter.
Mm-hmm. So equipment is installed. Behaviors are, having the equipment is good, is important, but the behavior is something that takes time to develop. And that's really essential because, like I said before, it's not the equipment that often fails. In fact, it's a breakdown in communication, or it's a procedure. That's what fails. So ensuring that the behaviors are fostered, having a positive safety culture where people are safe to speak up and question. This is really important. So I'm going to go through the prerequisites. So what do you need before you start? So there's lots of elements to that in terms of, obviously you need a bunker, things like that for a radiotherapy facility, but you also need for stereotactic, you're going to need the right immobilization equipment, the right pretreatment verification equipment. You're going to need the right things to make to do the quality assurance tests. But you're also going to need these process maps and process control. So all these things, and this is something I want to stress, is you don't just set up a program and then you've got a program. It's a living thing, and it's a living thing because it's made up of humans that come and go. You may have to retrain people. You may change an element of your equipment. So that doesn't mean that whatever you made on day one, you're going to be using it for the next 10 years. You should be revisiting it periodically, and it should be living and evolving with your institution and your practices. So these are some kind of elements of a culture of continuous improvement. You want effective leadership. You want support. You want to always be focusing on improving your methods. And you also want to have good, solid technology. But just remain vigilant, like stay on top of these things, and don't get complacent. It's easy to do. I mean, I'm speaking from experience. You get into something, you've done something for 10 years, and you feel really comfortable. But that can sometimes lead to errors. You get too comfortable, and then you're not paying attention to what you need to be paying attention to. So stay vigilant. And a lot of this stuff, a lot of these elements can be found in other literature. We're trying to make radiotherapy, especially stereotactic, where there's little room for failure. We want to make these highly reliable organizations, or we want to make our departments highly reliable organizations. And a lot of that stuff comes from airlines and from nuclear power plants. These are places where errors can't happen. And you think and it is at this point. I think radiotherapy has worked to become a highly reliable organization, or those styles. But these are the traits. So you're going to be sensitive to operations, so sensitive to the process and the system. Reluctant to accept simple explanations for problems. If something goes wrong, there's often the 5 whys. So there's the why did it go wrong? Well, because of that. Well, but why that? Well, it was because of something before that, and eventually, if you dial it down, you can find why it really went wrong, and it often it was a procedural error early in the chain, and you want to be preoccupied with failure. Realizing that even the most experienced individuals are still prone to errors. We still make mistakes. We're humans, so we want to stay on top of that. Defer to expertise, realizing that it is a team sport, and everybody brings their specific skills to the table. So respecting the individual skill sets is important, and being resilient, realizing that mistakes do happen, and they say is that the success isn't final, and failure isn't fatal. So if you make a mistake, bounce back from it and learn from it. So I mentioned this before, an efficient process is a safe process. And it's where those different system points interact. So focusing on making sure that you've got efficient processes is important, taking time to validate all the systems. And that's what we're going to talk about kind of with the end-to-end. That's probably the most effective way to assess your system. But also making sure that you've got a good, stable, steady team. If you're going to be doing specialized procedures like brachytherapy or stereotactic, you want to actually have a team that's focused on it and focused on it on knowing it very well. These are some organizational elements in terms of getting it right. There is an optimal workload, and like I mentioned, you don't want to be doing too few cases that you're not fully engaged and you're not getting the experience, and you don't want to be doing so many that you're fatigued. There's a balance to be had, and I understand financial constraints in terms of staffing, and also you've got the patients you've got, but be mindful of these things. Be mindful of the fact that there is a ideal workload. Too little or too much can lead to failures, and if you're in one of those danger zones, just be aware. That's the way to protect against it. Again, we mentioned before, duties and responsibilities of knowing our roles and responsibilities. That's important. And I see a question. 60 skull interfraction. It's just stability. Yeah, it's interfraction image in the correct skull motion change every minute. We often ignore adding PTV margins of benign tumors. I'm going to come back to this. I'm not saying that you can't achieve less than a millimeter. I'm going to come back to this one. And I know that a lot of people ignore PTVs. And one of the ways you can ignore a PTV is by having a gradient. So if you have the fall off and your peak dose is 24 gray, maybe you don't have a 2 millimeter margin, or you don't have a 1.5 millimeter margin, but you still have 18 gray at where that would be. So I think that's often used to account for that, and not always explicitly stated. So we are talking about the end-to-end and developing tests for the entire system. So the end-to-end testing is testing the whole system as it fits together. And I'll mention this again on a later slide. These shouldn't be black box. This first box could be your mask, understanding uncertainty associated with your mask. The next one could be image fusion. So if you're fusing MR to CT, individual uncertainties are like you're using a Winston Lutz to know how well you can position the target and then deliver the field. Knowing all those can allow you to assess or get an expected overall uncertainty. So you know that, okay, I've got a millimeter here, a millimeter here, a millimeter here, a millimeter here. You can add up the root mean square of those, and then you know what is achievable. So then when you get the results from your Winston Lutz or your end to end, you say, okay, well, this is matching up with what I believe I can do, or this is much larger than it looks like these individual components are. So what's the breakdown? And then the breakdown is typically where one of those points are, where one of those things connect. It might be that image fusion. So again, risk management, just making sure that you're paying attention to the whole process, and you've got good checkpoints, timeout procedures, and everyone knows what their role is, like making sure that the Winston Letts was done before the treatment. So you should do an end-to-end initially and periodically. It's not just one time when you're commissioning your system. It's annually is a good period, or it could be more often, or depending upon how many treatments you're doing. And this is kind of just showing, like, you're going through all these different points. You're looking at the imaging and the CT, the planning, then the alignment prior to and then the positioning, then the beam delivery, and then you're analyzing all these things together, and that's showing you all these. And you should also rely on, or if you can, use audits. I'm a big fan of audits. In the States, we have IROC, which is out of MD Anderson, and they credential for clinical trials. I know that there are other institutions that do credentialing for clinical trials. So they're ensuring a baseline level of quality so that data for the clinical trial is valid. And this is one of those phantoms. This is a lung phantom. It's got a target. It's got some organs at risk. In this case, heart and a cord. The cool thing is you're doing an end-to-end test, and then you're having someone external to you validate your system. And I think that's a nice thing. So this is always my preference for when commissioning, is to do credentialing at the same time. So you actually have an outside validation of your work, because we make mistakes. So it's not, there's nothing wrong with asking for help. Audits are good. So going back to kind of the process management, and it's a continuous thing. I mentioned before about complacency. Beware of complacency. And there's also a concept called normalization of deviance. So it's kind of got it's a big thing, but what it means is it's kind of like a slippery slope. You let one thing go, and then that thing becomes normal, and then you start skipping that process step, and maybe you let another thing go, and that can really come back and bite you. This is actually, I think, one of the things that they attribute to the Challenger disaster. I think a lot of people know that the O-rings they didn't expand the same in the temperature that they tried to launch. So that's what led to the explosion. But it wasn't that one event. It was actually that they'd gotten away with being like, okay, well, we're going to just do it anyway. They'd gotten away with it, and then they normalized that deviance. So that's where you can have these really tragic errors. So be vigilant and continually look at your processes and do that as a team. And again, this is kind of reiterating the audit element. Engage with outsiders. Right now you're I don't know how many people we have on the call right now, but this is a group. You have a group of professionals who are committed to this field and doing well in it. So I hope some of you are making friendships and forming connections outside of the overall organization, so that you can lean on each other and you can ask each other questions, because I know I don't have all the answers. I don't think any of the instructors have all the answers, but collectively we can answer a lot. So making arrangements, if you don't have something, that's also another thing, having friends and being friendly with other people. If you don't have something, maybe they have something they can lend to you. I don't have an end-to-end phantom. Oh, well, I've got one and I can lend it to you for 2 weeks or 3 weeks, whatever you need. And then, I mean, that's important. So, and beyond that, beyond the outside groups, like within our profession, for smooth operation in our departments, we need to have good relations with IT. At least I do. So, and also, you're referring physicians and things like this. These relationships are important. You should, before you start a program, you should know what kind of patients, or have an expectation of what kind of patients you're going to be treating. That kind of defines the need of your program. And you should be reevaluating this from time to time to ensure that you're providing what you need to your patient population. And maybe, you may find that I don't need to provide this because we only have so many patients, so we're never going to get good at it. So we'll send those patients over to so-and-so who will get good at it. I think it's important that we do recognize that doing these things infrequently is not always in the best interest of the patient. So doing it one-offs, sometimes it feels good to do it. It's not always in the best interest. We want to make sure that we're doing it right. So this whole process, all these things that I've been talking about is a form of prospective risk management. And this is a philosophy that's really been pushed by TG 100. And these things were all elements of highly reliable organizations. Nuclear power plants and airlines have been doing these kind of process mapping for years. And now we're trying to focus more on it in radiotherapy. So it takes time to create a process map. And the good news is a lot of them have been made, and you can always adapt them to your specific situation. But there are different ways to deal with risk. One is in a retrospective way where you make an error and then you learn from it through like root cause analysis. It's like using those 5 whys. But the ideal way is to know where your weak points are and strengthen those ahead of time. So I think there's a quote about that, you want to avoid the problems, essentially. You don't want to deal with the problems. You want to avoid the problems. So knowledge, it evolves with time and effort. Just like, I welcome the discussion a moment ago. This is how we learn. We don't learn just by sitting and reading a book. We do. That's only one part of learning. We learn by discussion with other people, and we should constantly be evolving and realizing that new things are coming. So having the experience, but reflecting upon the experience, thinking about it, and then how you can synthesize those new understandings. It should be a lifelong process. We're always learning. We're always being bombarded with data, with information. Taking the time to kind of parse through it and finding the connections is important. And I also included these 4 little elements, I think, of competence. So first, you're unconscious, incompetent. You don't know what you don't know. Then you're conscious incompetent. You don't know something. Then you're conscious competent. You're aware and you can do something. And then eventually you just do things naturally. And this last stage of unconscious competence is also, it's a double-edged sword. I mentioned this before because it can lead to complacency. So these are philosophies that I'm hitting on, but they're important to doing it right. And I mentioned just a moment ago, reading books is a form of passive learning, and even attending these webinars in some respects is a little passive. If you engage and you ask questions and you can always ask a question. It doesn't matter if I don't understand the question, that's on me. But the truth is, if you're trying to understand things and you're trying to synthesize these things, it's going to stick with you longer. So active is that interaction, is interacting with the knowledge, not just receiving it. And also, I'm learning right now. I'm learning by my readings with you and my experience with you. So taking the opportunity to present your experience at a local regional conference or something like that, that's a massive learning opportunity. You're sharing what you've learned, but you're also synthesizing what you've learned. So these are important elements. Don't just read it, practice it. So reviewing and assessing competence. I mentioned this before about you should have a minimum number of cases. This is at least how we approach it. And it's not my role to tell you how to practice. This is, but if you're not doing 5 cases a year, are you just relearning it every time? And is that doing the best thing for the patient? And is there a center that does do it 20 times, 50 times that might be a better service to the patient? These are just things to consider. These are some guidelines. They say 25 patients or more. If you're doing less than 10, it's not advised. If you're doing between 10 and 25, you should have some kind of periodic check-ins to ensure that you're supplementing your knowledge. So, and this is an awesome statement of that not all sites are the same. Like I said, the lung is not the same as the brain. It's not the same as the kidney. So medical devices, this is the equipment, having the equipment in place. This is going back to the kind of the stuff that you should have, knowing your immobilization system, knowing your imaging system and how they interact. So if you're doing a CT and an MR, knowing that fusion, uncertainty, quality, knowing your planning system, your IGRT system, and then obviously your LINAC or your beam delivery system. And again, I'm like repeating myself a lot. This is just kind of, maybe it's my style, but I'll go over things several times. You want to know what's achievable with your equipment. Like I mentioned, you want to know what your mask uncertainty is. You also want to know what your IGRT uncertainty is. These things you can assess locally. So I don't have like the prescriptive method for the masks, but there are pretty standardized methods for IGRT and fusion. These are all published methods. So, but knowing these allows you again to know what's achievable, and then you can kind of focus on the total uncertainty. And I mentioned this earlier too, is the end-to-end is the best you can expect. It's not a human, it's not breathing, it's not moving. It's this is the best you can get. It's a static patient. And there are different end-to-end test systems. There are different systems that try to incorporate some motion, but it's still not a human motion. There's no coughing. It's a very standard periodic motion. So again, these are idealized. Phantoms are still phantoms. They're not humans. So, if you're going to be employing some form of deformation, there are phantoms that can do that, but it's not the same. So it's an idealized. So this is the best you're going to get is with your end-to-end. So I also briefly mentioned the relationships with the IT, the making sure your data transfer is good is critical. I think it's less of an issue than it has been in the past, but I don't know what systems you all are using. I recommend a single manufacturer, and I'm kind of spoiled that I do have a single manufacturer. It does make things go smoother, but not all systems are created equal. And that doesn't mean that you can't still deliver a good treatment if you have mixed vendors, but you should be aware of where things can go wrong if you're transferring MLC files and things like that. And this is going back to the end. Components may be black box, but the system should not be. So one of those components could be I'm trying to think of, one of them could be like how it's actually doing the algorithms that are involved in deforming your tissues. If you're doing some kind of deformation and fusion, registration and fusion, those algorithms may not be something that you fully understand. You should be aware of their limitations, but you shouldn't treat anything as a black box. So just because you don't understand the mathematics behind the specific transformation doesn't mean that you can't assess it in a way to look for errors. There are different, I think image deformation is really a dangerous one, but it can go really wrong with like a liver. It can create swirls and things like that. So you don't need to know the math, but you should be aware of where it can go wrong. So I only urge you not to treat the system as a black box. Like I said, some elements maybe, but for the most part, try to dial it in as best you can and understand it as best you can. And I'm actually gonna come back to that one, but you want to know about the whole process and each element as best as possible. Humans are often the weak link. It's just the reality. Machines do things that are often reproducible. Sometimes we haven't had our coffee that morning, or we haven't been able to stop since 6 a.m. or whatever it is. So humans are often the weak link. So creating a process that can protect from human error is really important. But again, knowing this knowing your process and your system and protecting from those possible error points is important. So process control, this is just kind of making sure that you've got the whole chain, and we've been repeating a lot of this stuff, but just making sure that the whole chain is well understood and is operating smoothly. So you should map out your process on paper. You should do this before and then reassess after. You're going to be doing a flywheel. You're going to be reassessing. So plan, do, act, check. So you plan, you map it out, you do it, check what you've done, and then you see if there's any improvements to be made. And if there are improvements, that's the act phase. And this gets you better and better and better over time. So I just mentioned, I knew this was going to come up, or this was when I was talking about the black boxes. You want to dial in as best as possible, but the devil is in the detail, and this has a double-edged meaning. So one is, don't lose yourself in the details. Another one is recognize the important details. And this is a really hard thing. This takes professional judgment, and this takes some time. And this is also why teamwork is really effective, because when you work with a team, you're going to have 5 different perspectives. So you're going to have a better idea or a better feel for the scope. So when you're going through the process and you're looking at these changes, this should be done as a teamwork in a team fashion. And if you are implementing checklists, which is recommended, ever since I think that the checklist manifesto really popularized the use of checklists, but the use of checklists have been used in highly reliable organizations for a long time. And that's actually, I think in that book, he starts by talking about the improvements that are made by the use of a checklist in airlines and in flights. There's a lot of literature on building checklists, but it's not easy, and they can bite back. You don't want people to get fatigued by checklists, but each check should be thoughtfully designed. And there is, like I said, there's actually a report on this. But this is done in a team fashion. You shouldn't have physicists writing checklists for nurses without nurses' input. That's just like a recipe for disaster. You guys should be discussing these things together. And if whoever is implementing the checklist, they really should be a part of that process of developing it. So that takes effort. So that should be done together. And I mentioned this early. The culture is critical. So creating these safe processes and creating an environment where people are safe to call out errors or to cause for a timeout. That's really important. Never rush through one of these critical procedures. We know there's more patients to treat after this one patient, but when that patient's there, that's who we should be focused on. And that's the most important person in the room. So getting it right is critical, and creating a culture where people are free to speak up is really important. Elements of process control, we've hammered this, and this is like been interleaved throughout, is that end-to-end test. I'm going to mention class solutions. These are used more in Europe than in the States. They are valid, but there are drawbacks to them. And then we'll briefly touch pre-treatment verification. We're not going to go into in vivo dosimetry, and we're not going to go into the outcome analysis. But this is something that clinicians, I think this is something that we should always be doing. You should always be looking at not just what was in front of you, but the follow-ups and actually checking in and looking at your history and trying to learn and realize some gains that can be made. So,
Peter,
yeah.
That's fine. Can you explain what is a class solution test?
So we'll touch on it. So class solution test is you develop a class solution or you develop a treatment. And instead of QAing that treatment for every patient, it's a static treatment. So you use the same one, and it's already been established in a commissioning process. So say, for example, if you're just going to do a 4-field box, you're just going to do a 4-field box. And they do these with stereotactic and other things in Europe. They kind of have a formula, and they've validated that formula. But what I will mention is the fact that doesn't always give the best. That doesn't always give the best that you can get. It gives you something that's good enough, but that's up to the clinician to decide if it really is adequate or not. But it is I think it's a valid method, especially if you're dealing with high throughput. You've got a lot of stuff, but it's not always the best for each individual patient. So we've talked about this end-to-end many times, and I've got a little bag of turkey here. The thing is, I didn't. Well, I don't know. It's funny. Anyway, I did not include a bag of ham because this is often used, but I kind of knew my audience a little bit. So, but you've got a turkey here. You can always put an ion chamber in that and scan that and treat that. And this is something that we used to do a lot. So having one of these fancy phantoms is really great if you have one, but there are other ways to achieve these same things. And a turkey is great because it's got an air cavity, it's got different things, so you can actually it's not a human, but it's also not just a block. So it can you can scan that, you can contour that, and you can treat that. So there are lots of ways to peel an ore. And we've mentioned this before, assessing the individual elements. As a physicist, I think about the the dosimetry, and knowing about small field dosimetry is important. Localization, positioning, all these things. And then, one thing this table right here is also being mindful of your dose calculation grid. That's really critical. People have learned that the hard way. If you're going to be treating really small lesions, you should really have a small dose calc grid. If you're using a 3 millimeter calc grid or 2 millimeter calc grid, you're not going to get as accurate of a representation of the dose distribution. So being mindful of those elements and taking the time to kind of like dial it in and look through it. So mention again that the devil in the details. So just keep the overall goal in mind, making sure that the patient's treated safely and effectively, and just looking for those weak links. Again, be comfortable talking to other people, be comfortable asking questions to other people, and this is a hard one, but be comfortable sharing your failures with other people, because we can learn together. It doesn't feel good to make mistakes, but we do. And I think that has to be somehow normalized. We have a system in our hospital. It's a red cap system where all the errors are reported, and those are collated, and we look for opportunities to improve. A lot of times people will just fix an error and move on. But if you actually collect those are learning experiences, or there's learning opportunities, and those are improvement opportunities. But there always there's shame involved. I mean, I don't want to make mistakes, but I do. But I don't want to make them twice. So the way to do that is to acknowledge them and discuss them. So I mentioned this before about getting into independent audits. Those are good, because those can, you might make a mistake in your end, and it's always nice to having someone else involved or third party institution. This is I mentioned the class solutions. We kind of talked on it before. So class solutions are, so for all trigeminals, we use this beam arrangement, and we use this. That might be a valid approach for some treatments. It's not necessarily ideal for every patient, especially if you've got lesions in different places, or different sizes. So even established class solutions which have been validated should still be periodically rechecked to make sure that they're being implemented properly. And other pre-treatment verification, there's a whole AAPM task group, TG118, that goes into the tolerances. It's important that when you're implementing your system, that you're using different devices. Don't just use one thing don't just use one system to check it all and be done with it. There should be some kind of cross-checking, cross-validation, at least in the initial phase, and then periodically ongoing. This is something that's often neglected, is the QA equipment sometimes needs QA. And so sometimes you need to check the checker. And that's just part of the process. TG218 goes into more details on how to do this and how to establish your action limits. And just like the quality control system overall, or the quality management system, the setting your tolerances should be done iteratively. You should dial those in to get the best you can get, and using that as your action limit. So it should be done iteratively. So that was a long chat. I don't know. I think we're right on time. So it's about right. So high dose, I will read this slide to you. High fraction dose, high precision target positioning, treatment technique, requiring the highest levels of accuracy and safety in patient treatments. Errors in treatment often are irreparable and can lead to severe damage to the patient. Stereotactic is a high dose to the brain, intracranial. It's really dangerous. So we want to get it right. So setting up your program and constantly seeking to improve it is essential. So these are my take-home points to do stereotactic. We need dedication from the whole organization. It's a team sport, so we need everyone to be on the same page and supportive. Equipment, I do recommend a single manufacturer, but that's a preferable. The processes should be straightforward. Remember, an efficient process is a safe process, and it should be well defined with control points, checkpoints, timeouts, and your overall treatment quality control requires, you need those end-to-end tests and well-trained and experienced personnel. So you're getting the right experience and maintaining that. but those end-to-end tests will assess your system and show you where you can dial things in.